Case after case, 73. Now wait a second. 73. If you were looking at that mammogram, say moderately dense, would you say that this is a 73-year-old woman's mammogram? Would you? No? I would say these are viable TDLUs. So what's the explanation? Manipulation. Hormone replacement therapy. They keep the TDLUs alive. Watch out. You take it for 20 or so years. You can get anything on the step wedge. Even invasive carcinoma. Or hyperplastic breast changes. This is her previous examination. I don't think anybody can point out any pathology here. But then time passes by, and 2 years later, I'm positive that quite many of you would do this. Call back. What is it on the CC projection? I don't see it. Now, if you see something on only one view and don't see on the other view, work it up. On that view, you see it first, and then you go to the second view. Then, here it is. This is MLO projection, microfocus magnification, and you say that this is a radiating structure. I already looked at the skin. There is no surgical scar, no trauma. That is out of the picture. This is an elderly lady's very soft breast, and here is your finger, and it finds nothing. That gives me the idea, radial scar. Excuse me, radial scar is a proliferating disease. It's a hyperplasia. Let me tell you something, nothing proliferates over 70 unless you tease it, manipulate it. HRT. Could this be a radial scar? Well, let's go for it. Now you should better find it on the CC projection as well, can you? It's there. Oh, in that case, I try to think about that this is a radial scar, a black star. Look at this. Large, no central telomeres, but I see radiating lucency. Okay, good for her. White localization. You see, one is here, one is there. Good. This is going to be good. It's not good. Surgeon cuts through it again. The microfocus magnification increases resolution. Here is powdery calcification, and here is, I'm more and more convinced this is going to be a radial scar. Oops. I give up the thought. This is a central tumor mass and straight speculation, but this is black star anyway. So, is it white star? Is it black star? Soon we are going to find out. Dear colleagues, here it is. Oh, by the way, I didn't see it on a mammogram that there are two. Here is this, and here is a satellite. Mammographic histologic correlation. Here is the radial scar. The surgeon took out. And tell me, please, what this is. The surgeon cuts through a duct, not because the surgeon wanted to, but just happened to lead the knife here. What did I tell you? When it comes to radial scar, you are not allowed to be frugal like this. The pre-op negative core biopsy fooled the surgeon. I understand. He didn't want to cut big. Nevertheless, the core biopsy missed the carcinoma, okay, because this is cribriform cancer. What is this? This is fluid coming from the cancer cells. And here we have. This is a radial scar with a central fiber elastic core with the proliferating ducts plus a cancer. Let's look at the cells. Cannot be grade 3, usually not, and they are not. Otherwise, the woman in this age should look like this, extremely atrophic, skinny, wintertime, fat, fibrosis. Nothing else here, but you know what? You got to go back and send us another piece of tissue. Let's look at this one. Here is another slice. You see, women in this age should have this kind of wintertime image. Yeah, there is a little bit of proliferation here. Could this be a fibroadenoma? Look at this. This is a fibroadenoma. And this is atrophic, very atrophic just about everywhere. Look how boring it is. Oh, here is her radial scar. Fibroelastic core, proliferating ducts, no atypia, no nothing. One calcification, we didn't see it on the mammogram. Look how hyalinized it is. Look how structureless it is. There is no structure in this. Totally, very interesting. We have another one, and this is interesting, probably has more tissue here. Look at this beauty. Do you understand now, radial scar? Yeah. And if you do ultrasound, and this was exactly what we saw in the specimen X-ray, it's a fairly large fibroelastic core, and here are the proliferating ducts. Do we see another radial scar? Oh, here is the baby beside it. Look here. Here's a fibroelastic core with the proliferating ducts, but no cell atypia, no nothing. Otherwise, just look at this specimen, a radial scar 1, wintertime, radial scar number 2, nothing on the margin, nothing here, totally burned out desert fibroadenoma. Great. Anything else in this last one? Don't forget, we are talking about 4 microns. Compared to the mammogram, this is too thin. Here is one. Probably a baby radial scar. Sure, why not? Right beside the fibroadenoma. And so now we know this patient had multiple radial scars. This case was that 73-year-old lady who was on HRT that triggered the development of a difficult to detect radial scar, but eventually you found that no X-ray signs of malignancy. You take it out. Unfortunately, they came very close to the margin. This is the fairly large fibroelastic core. And this is what you saw. You see, the core biopsy was difficult because the tubular carcinoma may have the cross-section of these teardrop-like cross-sections, right? It's a good cancer, fluid-producing. They just have to go back and clean up the place. So much fibroelastic core. Here is the other one. I showed all these. You see, here we need a good pathologist to say, is this just florid hyperplasia? Why does it have this cribriform pattern? Look at the cell details. This is what John Azzopardi called sclerosing ductal hyperplasia. We call it benign neoduct genesis. So radial scar is not a good name. Lipid radiolucent material does not absorb the X-ray. That's why it's black star. Can be associated with anything on the step wedge, which you can miss. Like in this case, it was missed. Core biopsy is not recommended. But you have to start an intelligent discussion with your team members and the literature I showed you. But then you could say, sure, not a big deal. It's epithelial cell proliferation. No, you must not behave like that. So either hyperplastic breast changes are associated to hormone intake or high risk, like this 44-year-old woman, mother, both the maternal and paternal grandmothers had breast cancer. This is going to be quite a challenge for you. For everybody. Would you really call back for that? That notch on the contour? How would you evaluate this one? You would say the architectural distortion this size. You would say this is black. Calcifications? Well, either I ignore them, or I say, are these skipping stones? Lucency in the middle. Lucency here. Could this be a radial scar? Palpate. Nothing palpable. This was on the CC projection. Very subtle. But you see, the more pictures you take, the more convinced you are there is something there. And I would put my money on a black star. But whether they contain some epithelial instability, that's the question mark. That's why all radial scars have to be operated. And it's quite a large amount of tissue. Can we get help from ultrasound? When you see very dilated ducts, fluid-filled, and cystic cavities, then you think about Swiss cheese disease, juvenile papillomatosis, which is focal fibrocystic change, the little brother of this radial scar. I'm going to show you cases. Now, this is not fair. This is when I'm really blown away. Nevertheless, you see what you learned. Black star. Just look at it. And this is big. And where is your central tumor mass? I don't have none. Yes. I see a lot of hyperplasia. Here I see cysts and fibrosis, but peaceful. As a last case, should we cruise on that one too? I could. But actually, we could stay here and say, I really have to have explanation for the calcification. Did I get any? Well, that's a little crystal called some of my body-like calcification. Anyway, in this case, somewhere the pathologist found a 5 millimeter grade 1 cancer in situ AAB. But the whole thing is big, and I still don't know how much they left behind. Would you mind following her up? Yeah, sure, thank you very much. Now I should find the possible cancer when it's small, 2-3 years down the road. It's going to be difficult. So this is what I already told you: Hamperl, Azopardi, Black Star, Step Wedge. This I just leave because these are very well formulated for you whenever you listen to this lecture after it's going to be uploaded on MEI's website. Then you can take these sentences and teach your students. If you really want to be honest with the patient, the final and correct diagnosis can only be made after thorough microscopic diagnosis after surgery. Preoperative 14-gauge core biopsy or larger bore needle biopsy leaves a certain risk that you are going to have sleepless nights. When there are microcalcifications in the same area or in the vicinity of radial scar, they never help in the differential diagnosis, as I showed in this case, because either they are in the fibrous tissue, outside the glandular tissue, some of my body like powdery calcifications. No help at all. You are on your own. But I love ultrasound, as we all love ultrasound. In typical cases, it really gives me muscles. When does ultrasound fool you? When the fibroelastic core is too big, because then there will be the shadowing, and then you really have to do the core biopsy. And you might be surprised that I thought it was a cancer, but it wasn't. What about MR? Well, everything is in a limbo, because if it is fresh and not as burned out as one or the other I showed you, but viable, high metabolism, then it may be positive MR. I already showed you a case. Also, the Doppler can be positive.